Hi, I'd like to welcome back Dr. Aslanif, who has been giving us a lot of webinars on echo, interesting cases in echo. And I was very excited for this topic because I myself, as a cardiologist, will learn a lot and it becomes quite helpful in my practice. Of course, I don't see as many interesting cases as Aslanif, and I would like to congratulate Aslanif on two things. One is his twins. He's got a pair of twins now who are 7 months, two girls, and also he's just published yet another paper. I think he's 10th for IJN, right?
Yep.
Yes. So he's working very hard on both ends, both his career, his family, and also the academic part of cardiology. So without further ado, Aslanif, Happy New Year.
Thank you. Thank you, Dr. Betty, for
Please call me
inviting me
Betty.
again
Okay.
to giving this talk. So basically today, I will just share a few cases if I can. I just told Dr. Betty that I'm on call today, so I might need to leave early if there is some emergency going on. All right. So let's just start. These cases today are slightly more complicated than the case that I normally share. So we'll start with this lady that I just saw in clinic last week. She's 64 years old. She complained of shortness of breath, very severe shortness of breath at rest and at minimal exertion. When you look at her, she doesn't look so bad. She looks quite fit, but she complained of this exertion that really impacted on her quality of life. When I did echo, both transthoracic echocardiogram and transesophageal echocardiogram, it shows actually just moderate aortic regurgitation. So I have no idea why she have this shortness of breath. But obviously, the assessment of valvular heart disease can be very challenging. Some moderate valvular lesion might be severe, and some that is reported as severe might be moderate. So every time there is a discordant presentation of patient with what we interpreted in echocardiogram, it's always worthy to look back at the echo to make sure that we didn't do any mistake and to try to find out as much as we can. Because when we diagnose someone with significant valvular heart disease, this is a very big commitment because most of the time they need to go for open heart surgery. And just some tips. Most of the time, we only operate on severe valve lesions. So we don't operate normally on moderate aortic regurgitation. We wait until it becomes severe. So that's why this case is confusing. And in fact, this is a bit unique because most of my patients do not want to go for surgery or wanted to try to delay for surgery. But this patient and the husband keep pushing me to go and do the aortic valve replacement. So let's look at the image of the echocardiogram. So that's the transthoracic echocardiogram. As you can see here, you can see obvious aortic regurgitation. When we look at the color width and compare to the LVOT, we can see that the width of the jet is less than 50% the size of the left ventricular outflow tract. From here, it seems that it's not severe. It's important to remember that when assess the severity of valvular heart disease or any echo diagnosis, not to depend on just one parameter, rather to look at all the parameters and try to synthesize what is the correct diagnosis. So if with one image like this, you see something that looks moderate, does not necessarily that the final diagnosis is moderate. So this is one of the assessment. The other assessment is to zoom at the aortic valve and to put a color and to do a measurement of the neck of the aortic regurgitation. So this is what we call a vena contracta. And we measure it. If it's more than 6 millimeter, it's severe. And again, this is only 3.5 millimeter that shows moderate aortic regurgitation. So there are two things here that show moderate aortic regurgitation, right? So still it's not enough. We look at our apical four-chamber view. And we can see here that the left atrium is also normal. The left atrial volume index, the upper limit is 28 mils per meter squared. That's a new upper limit of left atrial volume index. And this patient LAVI is normal, which is extremely rare in patient with severe valvular regurgitation. When you look at the left ventricular dimension, the LV systolic dimension is 3.15 centimeter. In severe IT regurgitation patients who are asymptomatic, we take a LV systolic dimension of 5 centimeter or more, or 25 millimeter per meter squared if we index to body surface area to consider surgery even if they are asymptomatic. In fact, there are recent studies that shows that we might need to reduce this to 20 millimeter per meter squared. What I mean is that the size of the left ventricular measure at this parasternal long axis view. And so the left ventricle is still small, again, against the diagnosis of severe aortic regurgitation. When you look at the apical four-chamber view and we see at the ejection fraction, the ejection fraction is relatively preserved at 7.5%. For asymptomatic severe AR, the threshold for aortic valve replacement is ejection fraction that is 55% or less. Again, it hasn't crossed the threshold to do surgery. This is something that is important. This is a LVOT, velocity time integral, across the aortic valve, across the left ventricular outflow tract. If you trace this LVOT VTI, the normal value should be 17 plus minus 3 centimeter. Anything above is indicated of high stroke volume. Anything below is considered low stroke volume. So this patient LVOT VTI is 18.1 centimeter, is within the range of 17 plus minus 3 centimeters. So the stroke volume is also normal. Again, this is not indicating severe IT regurgitation, because in patient with severe IT regurgitation, you expect the stroke volume index to be significantly increased. When we put a pulse wave Doppler in the descending aorta, this is to look at hollow diastolic flow reversal. So this is the forward flow during systole. This is the diastolic reversal. In a patient with significant aortic regurgitation, especially if you were to pulse at the abdominal aorta, and you see this hollow diastolic flow reversal, that is indication of significant aortic regurgitation. Now, in this case, even at the descending aorta, you see that there is diastolic flow reversal, but it's not very impressive. In fact, the velocity time integral is only 6.3 centimeter, and there are studies that shows that 13 centimeter is the threshold that we use to say that the aortic regurgitation is severe. The max velocity of the tricuspid regurgitation is less than 2.8 meter per second, showing that at rest, the left atrial pressure is not elevated. Again, we look at this patient diastology and diastolic function. The septal and the lateral E prime is slightly reduced. The septal E prime is 6.67. The upper limit is 7. The lower limit is 7. The lateral E prime is 7.54. And the lower limit is 10 centimeter per second. So the tissue is slightly low. But when we look at the average septal E over E prime, the value is 12.1. The value to say that the LA pressure is elevated is more than 15. The value of 12.1 is in the gray area. Remember that the value of more than 15 is specific but not sensitive, meaning that there are many patients with the E over E prime that is less than 15 and they can still have elevated LA pressure at rest. Now, from this thoracic echocardiogram, we see multiple indications, from the jet width to the vena contracta, to the size of the left atrium, to the size of the left ventricle, to the supportive sign of diastolic flow reversal, that show that this is only moderate aortic regurgitation. So it is a non-severe. So if this is a moderate aortic regurgitation, this should not cause any symptoms. So why the patient is symptomatic? The only possible other explanation is the diastolic dysfunction. But as I've shown you, the diastolic dysfunction seems to be grade 1. The LA pressure seems to be normal at rest and not elevated. Now, since she's still very symptomatic and I still don't know what is the reason, I decided to do a transesophageal echocardiogram to again make sure that I didn't miss any severe aortic regurgitation. And this is the transesophageal echocardiogram. As you can see, this is the aortic valve. That is a mitral valve with a long axis view. This is the aortic regurgitation. And again, the transesophageal echocardiogram also points towards moderate aortic regurgitation. You can see that the aortic valve is tri-leaflet here. And you can see that maybe there is slight thickening at the leaflet tips that cause this aortic regurgitation. So we have a transthoracic echocardiogram and transesophageal echocardiogram that shows moderate aortic regurgitation. What do I do next? So I have done a resting transthoracic echocardiogram. I have done a transesophageal echocardiogram. And the only other thing that I can think about is diastolic stress echocardiogram. Diastolic stress echo
Can I
is the...
stop you here?
Yes, sure.
Okay. Would you have thought of other diagnoses like coronary artery disease to explain the shortness of breath? Because as a woman, right, sometimes the presentation for coronary artery disease is not chest pain and it can be atypical.
Yes, I didn't mention it because otherwise it will be a long presentation.
Okay.
I have done every single thing. I mean, that I think a cardiologist should do. You know, looking at the lung, looking at the kidney to try to rule out the
Okay.
coronary is clean. So I couldn't explain.
Okay, so her coronaries are clear, her lungs are fine, and now we're just concerned whether it's the aortic valve and to send her for... Okay, the other question I'd like to ask you is, this diastolic dysfunction, right? Would you really see it as something that will cause symptomatic shortness of breath or even leg swelling or clinical heart failure in a 64-year-old lady?
Definitely, this is one of the commonest things that I
Even at
see that cause
64,
shortness
yeah?
of breath.
Mm,
Definitely.
okay.
So we did a diastolic stress echocardiogram. This is a test that I implemented in Institut Jantung Negara. I think that we are the only center in Malaysia at the moment that do this diastolic stress echocardiogram. The principle behind this test is that in the patient with chest pain and exertion, you exercise them to look for changes at exercise to diagnose exercise-induced angina. And similar things should go for shortness of breath. With the shortness of breath and exertion, we should exercise the patient, and we want to see whether the LA pressure is actually increased at exercise. So as you can see here, these two images are her diastolic parameter at rest, and these two images are the diastolic parameter at stress. As expected, the E velocity go up from 58.7 to 78.8 centimeter per second, right? But surprisingly, the E prime, which is the relaxation, also increased from 5.1 to 8.6 centimeter per second. This shows that she have quite a lot of good diastolic reserve. In fact, rather than increasing, the septal E over E prime actually come down from 11.5 to 9.2. So this is a negative diastolic stress echocardiogram test, i.e., when I exercise her filling pressure stay normal. So
Okay,
with this
can you explain what would have been the abnormal parameters? Because I myself don't do this at all.
So basically, when we want to do diastolic stress echocardiogram or anyone, when they exercise, the E velocity will increase.
Okay.
Even if they have diastolic dysfunction, if they don't have diastolic dysfunction, the E velocity will increase with exercise.
Okay.
But the E prime, which is a tissue Doppler parameter, is preload independent, i.e., at exercise, if you have a low E prime because your tissue is really sick, normally you are not able to increase that E prime velocity. If your tissue is well and healthy, usually the E prime will increase along the E so that your over E prime will stay about the same at exercise. So the threshold to say that the LA pressure is elevated is the septal E over E prime go from normal to more than 15. In this patient, as you can see, that the E over E prime actually come down to 9.2 at exercise. Right. No, not only that, we also look at tricuspid regurgitation max velocity. The max velocity is 2.04 centimeter per second at rest. And as you can see at exercise, it only go up to 2.47 meter per second. the threshold to say that the LA pressure is elevated at exercise is 3.2 meter per second. Again, negative. So basically, I can confirm almost to 100% certainty that diastolic dysfunction is also not a problem for her, right? So what do I do next? Okay, and this is my last steps, okay, to really convince myself that this patient does not have any heart abnormalities. So I do what we call a speckle strain. The strain is relatively new, not so new. I think we have had it for more than 10 years now. Of looking at the LV, LA, and RV function in a way that is more sensitive. It is more specific and is more reproducible. What I mean to say is that when this ejection fraction might be normal, but the strain can be less than normal. So the strain actually come down much earlier before ejection fraction. So if your strain is normal, it is very unlikely that you have any significant left ventricular problem. And as you can see here, when I do global longitudinal strain for this patient, you can see that most of the bullseye view is red. Red is very good. And you can see that the average GLS for this patient is negative 20%. Any value that is more negative than negative 18% is considered normal. So this patient have normal global longitudinal strain. Not only that, I also do a left atrial strain. A patient with elevated LA pressure will have an LA strain of 30% or less. This patient have a LA reservoir strain of 45.4%. And even a normal right ventricular free wall strain of 26.1%. So she have absolutely normal strain in every chamber of her heart, except of the right atrium, which at the moment I didn't measure. So in summary, ladies and gentlemen, in this patient with a very complicated presentation, I have done a comprehensive assessment and I have certainly determined that the aortic regurgitation is moderate. The aortic regurgitation haven't affected the left ventricle and it shouldn't cause the symptoms that the patient is having. And the GLS really reassured me that there is no significant cardiac problem, because we would expect someone with severe aortic regurgitation and extremely symptomatic should have reduction in GLS, which we didn't see here. Even if we think about diastolic dysfunction, significant diastolic dysfunction, we would expect at least slight reduction in global longitudinal strain. And more importantly, the LA reservoir strain can be a reflection of LV filling pressure. And the fact that LA reservoir strain is completely normal is again cardiac cause of dyspnea. The grade 2 diastolic dysfunction, the reservoir strain is usually less than 30%. And in grade 3 diastolic dysfunction, the reservoir strain is less than 20%. And after all this, I actually tell the patient that even though they are pushing me for surgery, I think that it is unethical for me to proceed surgery without any good reason for her to go for the surgery. So I refuse to send her for surgery, though I do ask her to go and ask for second opinion and to see other cardiologists to make sure that there are nothing that I'm missing. So that is my first case.
Interesting. But would you treat her symptomatically, for example, with some low dose of diuretic, or even, let's say, the use of SGLT2 inhibitor in this case?
So the problem with doing that is number one, I do not have any evidence whatsoever that her LA pressure was elevated. The reason we give diuretics like furosemide for someone is to reduce their LA pressure and to make them not symptomatic. And the evidence for SGLT2 inhibitor is both for HFpEF and HFrEF that have some evidence to tell the patient have HFpEF and HFrEF. So that's why I didn't give it. Another thing is that I do not want to give her any placebo effect. I mean, I might give her furosemide and she might feel better, but that is not, I don't think that is not really solving her problem by giving her medication, because even though we know that these medications are safe, but there are no medication without any side effects. So I do not want to give her anything.
The other thing is, I assume that clinically she is not in failure whatsoever, right?
Yep.
Yeah,
The
so
lung
her
is
lungs are
clear.
not bad. She's got no ankle edema, nothing. It is just based on her symptom, her complaint of shortness of breath, but there were no signs of heart failure, right?
Yep.
Okay, so obviously your assessment correlates to this clinical findings. And sometimes it's true, sometimes you cannot take patients' symptoms just like that, because there are many other things that could cause her to be short of breath. Okay, good one.
All
Next.
right. So let's go to case number 2. So we have here a 66 years old male with atypical chest discomfort, also have exertional dyspnea. He was diagnosed with hypertension only 1 year ago. Again, we look at the echocardiogram. At the parasternal long axis view here, what is striking is the fact that the interventricular septum here, as you can see, is thickened. The thickness is 1.8 centimeter. Upper limit for male is 1.1 centimeter, and upper limit for female is 1.0 centimeter. So when you have a thickness of 1.8 centimeter, you have to explain that. The thickness is asymmetrical. The interventricular septum is 1.8 centimeter, but the inferolateral wall is about 1.2 centimeter. Whenever we are measuring the thickness of the wall, because this have implication to our diagnosis and management, it is very important to measure it in two views. So I not only measure it in the parasternal long axis view, I also measure the wall in the short axis view. And this basal anteroseptal, the analogous position in short axis view is right here. And from here, I also measure the wall thickness, and the thickness is also similar at 1.8 centimeter. In fact, the short axis view might be better because you can actually exclude more in your measurement. When we look at apical four-chamber view, you can see that the ejection fraction is borderline depressed at 50%. Let's look at the apical two-chamber view, and you can see there are significant hypokinesia at this basal inferior wall. So these are the inferior wall and these are the anterior wall. So we have to explain two things now. Why does the patient have quite significantly severe abnormal left ventricular wall thickness? And why does this patient have severe hypokinesia in this basal inferior region in the apical two-chamber view? When we look at the diastology of this patient, so this is a mitral inflow with E over A of less than 0.8, E velocity of less than 50 centimeter per second. Using 2016 ASE diastolic guideline, we can straight away say that this is a grade 1 diastolic dysfunction with normal filling pressure. Remember that this is only true if the E velocity is less than 50 centimeter per second. This is a pulse wave between the mitral valve and the aortic valve. The reason we do this is because we wanted to see the flow into the left ventricular outflow tract and also the mitral inflow, because the duration between this and this is what we call the isobolometric relaxation time. The normal value of isobolometric relaxation time is between 70 to 100 milliseconds. Anything above 100 milliseconds is impaired relaxation. Anything below 70 milliseconds is suggestive of increase in left atrial pressure. So below 70 is much worse than above 100. Anything between 70 and 100 is normal. So still grade 1 diastolic dysfunction with normal LA pressure at rest. When we look at the septal E prime, however, we can see that the septal E prime is very low at 3.92 centimeter per second. So the tissue of the heart is very sick. The lateral E prime is also low at 5.53. I remind again that the threshold for septal is 7 and for lateral is 10. We can see that the septal E over E prime is 12. Again, this is less than 15 because more than 15 is specific for elevated LA pressure. So this is 12. So we can say that the LA pressure is probably not elevated. Again, telling us that this is grade 1 diastolic dysfunction. So what is the issue with this patient and what is the discussion here? So basically this patient have a thick wall issue, right? Now, hypertension can certainly cause the patient to have thick wall, but normally I would say that 1.5 centimeter is probably the maximum you can have with hypertensive cardiomyopathy. Even though in rare cases it might go beyond that, but if you have 1.5 more than 1.5 centimeter, you need to think about other differential diagnosis. The differential diagnosis for wall thickness that is more than 1.5 centimeter basically is three. The commonest is hypertrophic cardiomyopathy, followed by cardiac amyloidosis, and followed by Anderson-Fabry disease. So in this case, can we differentiate hypertensive cardiomyopathy and all these three diseases, right? Now, asymmetrical wall thickness may point towards hypertrophic cardiomyopathy because in hypertensive cardiomyopathy, in cardiac amyloidosis, in Fabry's disease, usually it is symmetrical, but not necessarily so. So we cannot use that 100%. There is no systolic atrial motion of the mitral valve, but remember that SAM is not needed for hypertrophic cardiomyopathy diagnosis. In fact, SAM can happen in cardiac amyloid, SAM can happen in Fabry disease, can happen in hypertensive cardiomyopathy, can even happen in patient with apical myocardial infarction, as long as the LV is hyperdynamic with apex more, with the basal more hyperdynamic than apex. However, when we do coronary angiogram, it actually reveals severe triple vessel disease. And now we have an answer of why that hypokinetic segment in the inferior wall in apical two-chamber view. So now we have an explanation for that, but not why the patient has thick wall. So what can I do next? Of course, I can order cardiac MRI. In fact, in all patients with thick wall cardiomyopathy, I will order cardiac MRI because I think that that is really something that can tell you more about your differential diagnosis. But in many echocardiogram now, we can easily do strain. So I do strain. And I think this is where the strain can come to the rescue and tell us what is the most likely diagnosis in this patient. So this is the global longitudinal strain of the patient. Number one, the GLS is negative 11.6%. Okay, normal value is more negative than negative 18. So negative 19, negative 20, negative 21, negative 22, so on and so forth. So this is extremely low. And we don't expect patient with hypertensive cardiomyopathy alone to have this low of a GLS. So we can rule out hypertensive cardiomyopathy alone as the cause of this low global longitudinal strain. Of course, coronary artery disease can be one of the reasons. But when you look at the bull's eyes view of this global longitudinal strain, you can see that the greater reduction of the global longitudinal strain actually coincide with the region of the thickest left ventricular wall. And these are extremely suggestive of hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, what differentiates it from the other thick wall cardiomyopathy is that you have a significant reduction of GLS at the region where the wall is the thickest. So the thicker the region, the worse the GLS. So if you have apical hypertrophic cardiomyopathy, you have GLS that is very reduced in the apical region. If you have a sigmoidal, a reverse curvature hypertrophic cardiomyopathy, the reduction will be most at the septum. So even with strain alone, I can say with almost 99% certainty that this patient have hypertrophic cardiomyopathy coincide with coronary artery disease.
But it's not obstructive, right?
Oh, sorry, it's not obstructive. So it's hypertrophic cardiomyopathy with concomitant coronary artery disease.
So his symptoms are most likely due to the severe triple vessel disease.
Most likely severe triple vessel disease.
Yeah, so the fact that we are studying the hypertrophy is actually basically academia, right? Academia.
It's not academia because if the patient have hypertrophic cardiomyopathy, number one, it can explain why the chest pain, because a thick wall, because the vessel is epicardial. In order for the vessel to penetrate the heart, the thicker the wall, the more unlikely for the vessel to penetrate all the way to the endocardium. So hypertrophic cardiomyopathy can cause chest pain. That's number one. Number two, hypertrophic cardiomyopathy patient have risk of sudden death. Even though the wall thickness is not very, very thick, but that doesn't mean that the risk of sudden death is zero. Number three, it's important because we want to do a cascade screening of the family member because they might also have hypertrophic cardiomyopathy. And number four, the patient with hypertrophic cardiomyopathy have a risk, albeit very small, to develop burnout, HOCM, and heart failure at the end of the process. So I think that's all the reason why it is important as well to determine what is the reason the patient
Okay.
have.
For example, you just did the strain. Okay, I don't understand the strain very well because, okay, so first I would like to ask you, what is the strain pattern available in most echo machine?
I mean, most echo machine, I'm not sure about the echo machine outside.
Mm-hmm.
But most echo machine that is new, I think maybe 2020 and above, usually they have included in their software this
I
spectral tracking.
see. Okay. Two is I would like to ask you, if let's say the strain pattern looks abnormal now, if you were to revascularize the patient either by doing an angioplasty, triple vessel angioplasty or a bypass, would you think that the strain pattern would improve?
Definitely. In fact, one of the nicest way to follow improvement in patient is by doing the strain. Because if you think about, even for coronary artery disease, if they have improvement, but sometimes in coronary artery disease, the good thing is that most patients with significant coronary artery disease, they have reduced ejection fraction. So you can track the improvement by looking at the ejection fraction improving. But a patient with hypertrophic cardiomyopathy, most of them has preserved ejection fraction. And sometimes you don't know with preserved ejection fraction how to track the improvement in whatever you are doing. So you can use strain because even though their EF is preserved, you can see the strain improve.
Okay. This is
And finally, okay,
sorry.
you saying something?
No, you're breaking up.
Okay. Am I? Can you hear me?
Yeah, I can hear you now.
All right. So finally, this is the LA strain. Again, the LA strain is low at 27.6%, showing that there are significant diastolic dysfunction in this patient. Right. So in conclusion, in this case, strain actually helped me in thick wall cardiomyopathy differential diagnosis. I can safely rule out hypertensive as the strain is significantly down, and hypertension alone is unlikely to cause marked reduction in strain.
Okay, I like to differ on this because you studied the patient on the strain before he was revascularized. So the strain could be significantly down because he has severe triple vessel disease.
That's what I said just now. Remember, I said
Yeah, that's right. So, but
I
you
said
said
that this,
yes, you said that, but now you say that the hypertension is unlikely and is most likely to be cardiomyopathy, hypertrophic cardiomyopathy that is causing the strain to be significantly down. But the strain could be down not because of the hypertrophic cardiomyopathy. It could be down because of the severe.
so we have two areas. Number
Yes,
one,
area.
normally a coronary artery disease does not cause a thick wall. So we can see that the greatest reduction in strain happened at the region where the wall is very, very thick. So that is the reason, one of the reasons the strain is reduced. However, there are some other region of the left ventricle where the strain is reduced because of that coronary artery disease.
Yes, okay. Oh, I see. So your reduction in strain is greatest where the wall is thickest. Okay, I understand now. And the pattern is not typical of amyloid, yes?
And yeah, furthermore, when you look at the global logarithm strain bullseye pattern, the pattern is not typical of amyloid because in amyloid you will have apical sparing. It's not typical of Fabry disease. Fabry disease, the reduction is confined in the basal infralateral wall, at least at the beginning, or even constrictive pericarditis, because in constrictive pericarditis, usually the reduction is at the basal and mid infralateral wall.
How long do you spend on the echo on a patient?
Long.
Okay, what's the last conclusion that you can make?
It's just that I use the LA reservoir strain as a tiebreaker in patient where I can't really tell whether the LA pressure is elevated or not. Sometimes when all the parameters are a little bit all over the place, LA reservoir strain is very useful. If it's less than 20%, almost certainly the LA pressure is elevated. If it's less than 30%, likely. If it's 40%, the LA pressure is most likely is normal.
I can't believe you spend so much time on the the ventricle septum thickness. I just want to do the angioplasty. Okay, let's go to the third case. Well, today's
So,
cases all very heavy, huh?
yep.
Because
All
we're
right.
talking about things that I don't know. Okay, go on.
So this is case number 3. So these are also a very complicated case. These are 31 years old female with known case of hypertrophic obstructive cardiomyopathy. She did TASH. TASH is transseptal alcohol septal ablation. Okay, so in
Oh,
TASH,
okay.
what they do is that for those of you who doesn't know, these are a catheter-based treatment for hypertrophic obstructive cardiomyopathy, where you do a coronary angiogram, and then after that you find a septal perforator, a branch of the left anterior descending artery that supply the segment where you think the wall is thick that caused the left ventricular outflow tract obstruction. Then you actually put an ethanol there to cause a localized myocardial infarction at that thick wall, in the hope that the area of that thick wall will come down and you will reduce your LVOT obstruction. It is a very good procedure, very good in reducing obstruction, but it's not the gold standard. The gold standard is still surgical myectomy. Okay. Now, the problem here is that I see her recently in my clinic. After TASH, she got brief symptom release, right? But then the shortness of breath come back with a vengeance. For her, it's even more different because you can see that the jugular venous pressure is elevated. And you can see that the NT-proBNP is in 1,000 and it's keep increasing. And she, even more problem, she is keen on getting pregnant. Okay, 31 years old, shortness of breath, getting worse, NT-proBNP is elevated, and also want to get pregnant. So this is the echo done. Okay, I just wanted to show you. I think this was echo done in, 2022. Okay, this is in 2022. If you look at the parasternal long axis view here, you can see that there is an asymmetrical increase in wall thickness. The ejection fraction at that time is 56%. The maximum wall thickness is at the basal towards the mid-anteroseptal wall. The wall thickness is only about 2.0 centimeter. Upper limit for female, is about 1.0 centimeter, right?
Yeah.
But you can see here, obvious SAM. You can see that the anterior mitral valve leaflet actually touches the interventricular septum during systole. And this causes dynamic left ventricular outflow tract obstruction. So whenever the LV contracting, the leaflet go and touch the septum and obstruct the flow of blood from the left ventricle into the aorta. Again, as I always said, I like to double check my measurement from parasternal long axis view to the short axis view. As you can see here, you can see this is actually the real thickness of the left ventricle. From here to here is actually the right ventricle, right? So make sure that you don't also measure the right ventricle in the measurement. Otherwise, your measurement will be erroneously high. You can see here, this is a zoom view of that SAM. I show this because I wanted to show you a typical color flow of dynamic LVOT obstruction. You can see a Y-shaped turbulent flow because of the obstruction here and the leaking here, right? Why does this patient have this kind of pattern? So remember that when you have systolic anterior motion of the mitral valve, normally the anterior mitral valve leaflet is pushed towards the interventricular septum. As it pushes towards the interventricular septum, the contact or the closure of the mitral valve leaflet, the surface area that is available for closure is coming down, because normally you need at least 10 millimeter length of this closure area. So therefore, normally you will get this posteriorly directed mitral jet. If you see a mitral regurgitation that is anteriorly directed or a centrally directed mitral regurgitation, this is unlikely to be caused by SAM. So in that situation, you might have to think hard. Is this because of SAM or is it because primary mitral valve problem? Right, but in this situation, this is a classic one with the Y-shaped turbulence flow. Okay. In terms of the sequence, remember that the sequence of the blood flow is eject, obstruct, and leak. This is the M mode across the mitral valve, M mode is good. Why? Because it have a very high temporal resolution with a frame rate that goes up to 2000 bits per minute. So you can see a moving object very nicely from M mode. As you can see here, this is the anterior mitral valve leaflet open in diastole, and in systole it should close. But you can see that during systole, the anterior mitral valve leaflet actually go here and touch the interventricular septum, and
Oh,
therefore cause the left ventricular outflow tract obstruction. Again, you can see a normal mitral valve opening during diastole. At systole, again, you can see this movement of the mitral valve, anterior mitral valve leaflet to the interventricular septum. So this is SAM, 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 right? Now, these are also important. Why? Because the duration of contact of this anterior mitral valve leaflet to the interventricular septum and the timing of onset from the end of diastole to the onset of that SAM septal contact is very important. So if you do a ratio of the duration between the end of diastole to the contact over the duration of contact, the lower the ratio, the more severe the left ventricular outflow tract obstruction. Okay. Now, this is the apical long axis view. So we use this to measure the LVOT obstruction. Okay. You can see here there are two flows. One is the mitral regurgitation flow, and one is LVOT obstruction flow. And this can be very tricky. This is one of the most difficult things to approach in echocardiogram. It is to differentiate which is which when you do Doppler, because you do not want to contaminate your LVOT flow with your mitral regurgitation flow. Because you have to remember that MR is a gradient between a very high LV systolic pressure and a very low LA pressure. So MR gradient will always be high. So you do not want to measure the MR and say that this is the LVOT obstruction. Okay. So how do you do that? The tips is go to the MR Doppler straight away and measure that Doppler max velocity. So just go directly to the MR and measure the max. The max should be at least 5 or sometimes 6 or 7 meters per second. And your LVOT peak velocity will always be lower than your MR velocity. Okay. So after you have done that, then you move your cursor towards the LVOT, use a pulse wave Doppler until you get an aliasing, and then change to continuous wave Doppler. After you change the continuous wave Doppler, you will get something like this, right? And when you get something like this, number one, you see is the peak velocity lower than the peak velocity that you get from the MR. It have to be lower. If it is about the same, beware. You might maybe measuring the MR jet. That's number one. Number two, look at the shape of the Doppler. Okay, MR Doppler is parabolic, whereas LVOT Doppler is late peaking, and this is a late peaking shape rather than a parabolic shape. So we have a second thing here that we do to reassure us that this is an LVOT Doppler. And finally, we look at this width here, right? The width of MR is wider because mitral regurgitation actually involve the isovolumetric contraction and isovolumetric relaxation time. Okay, for your LVOT obstruction, is only involve the ejection time. Okay, so you make sure that all three are correct, then only you can say that that is your LVOT gradient. In this patient, the max LVOT gradient is 90.2 millimeter mercury. I just wanted to remind you, the definition of hypertrophic obstructive, if you want to say that the patient have hypertrophic obstructive cardiomyopathy, the peak gradient must be more than 30 millimeter mercury. And certainly in this patient, the gradient is more than 30. Okay?
Okay, do you use pulse or continuous in
Continuous
the
wave Doppler. Why? Because a pulse wave Doppler cannot measure velocity higher than 1.5 meter per second. You will get aliasing.
So you use the,
Continuous wave Doppler.
when you measure the aortic valve, you use the,
Continuous wave Doppler as well.
for LVOT also.
No, for LVOT, you have to use pulse wave. In a patient that don't have LVOT obstruction, and you want to measure stroke volume of
You
the LV,
measure, that's right.
you
You
have
use
to use a
pulse.
pulse wave Doppler.
Okay, but in this case, you use a continuous wave.
Correct, because the velocity is much higher than 1.5 meter per second.
I see. Okay, okay,
Correct?
okay.
Okay, so if you want to say obstruction, it must be 30 millimeter mercury. But if you want to say significant obstruction, okay, and to qualify this patient to go for septal reduction therapy, either test or myectomy, it have to be more than 50 millimeter mercury, and the patient must be persistently symptomatic even on medical treatment. One more time, if we want to consider a septal reduction therapy, the gradient peak must be more than 50 millimeter mercury, and the patient must be on medical therapy and still be symptomatic, right? By the way, these are all echo after the test, right? So even after the test, the patient has significant gradient across the LVOT. Okay, that's why she is symptomatic.
I have a patient that with the similar, she's actually an Indonesian maid. Her boss brought her to see me, and she fainted twice or 3 times before coming to see me. And she has obstructive hypertrophic cardiomyopathy. And I put her on a beta blocker. She's much better, but she can barely exert herself too much. The moment she exerts herself too much, she will faint. Yeah, even
Horrible.
on beta blocker. And
So
I,
this is the case where you want to
yeah,
consider.
that's right. I now that you mention it, I think the gradient is more than 60. Yeah, I will speak to them, but they probably can't afford. That's the problem.
Yep. All right. So let's continue. So what's the discussion about this patient? Okay. Her symptom is getting worse, right? Apart from tracking her NT-proBNP that is going up, I was thinking that is there other way to see progression? Because the EF tend to be preserved in patient with hypertrophic cardiomyopathy. I think by now you already know what's the answer. So the answer is to do strain. Because when you do strain, you can actually track the progression. What is the other problem? Now, the echo interpretation of wall thickness can be erroneous. You know, when you measure the wall thickness, it's very, very difficult. It's not as easy as it seems. In fact, there are studies that shows even a similar person, you get that same person, measure one time, ask the person to go out of the door, then come back in and measure another time, he will measure a different number, right? So that wall thickness can be erroneous. And it's difficult to correlate the degree of increase or decrease in wall thickness with disease progression. So for example, if I measure wall thickness now of 2 centimeter, and I measure wall thickness in 6 months is 2.2 centimeter, number one, I'm not sure whether my measurement is correct. Number two, how sure I am that an increase of 0.2 centimeter actually caused the symptoms. So that is the tricky part when you want to manage these patients. And like I said, most patients with HOCM have preserved EF. So EF is not so useful in tracking progression. And ideally, we want to prevent patients from going to burnout HOCM. Just to tell those that who doesn't know, patient with hypertrophic cardiomyopathy, lest you think that this is a disastrous diagnosis. For those of you who diagnose hypertrophic cardiomyopathy, the outcome of the vast majority of hypertrophic cardiomyopathy patients is very good. 95% of hypertrophic cardiomyopathy patients live a normal and productive life. They have a similar longevity as other people. The problem is only the 5%. And the minority of this 5% can even go into burnout HOCM, in which from preserved ejection fraction, they go into low ejection fraction, and they do behave like patient with heart failure with reduced ejection fraction. And these are very dangerous cohort of patients. Okay? Now, what follows are her latest echo. This is a latest echo done recently. Okay. This is done in 5th of January 2024. Okay. Now, again, you can see here in the parasternal long axis view, you can see SAM of the anterior mitral leaflet. You can see the dynamic LVOT obstruction with posteriorly directed MR-jet. But when I measure the wall thickness now, the thickness is 1.8 centimeter. Somehow it has come down 0.2 centimeter. But remember about what I said before about the trickiness of measuring this, okay? There is SAM with similar color flow pattern of obstruction and regurgitation. Remember that even though the wall thickness is coming down, she's actually getting worse. She's feeling worse, okay?
So the wall thickness is reduced because what do you do to it?
No, we didn't do anything.
You didn't do anything.
Yeah.
But
So either I measure incorrectly, which is can be very possible because Like I said, it's not easy to measure. Different of 0.2 centimeter mistake can
Yeah, it
easily.
doesn't matter, right? And it's not variable, right?
Yep, correct.
Yes. So I
Yep,
don't think that we should take in account in that when
yep,
we assess the patient. I think the obstruction is still there.
yep. The obstruction is still there, definitely. Right. So
Yeah.
the SAM, there is SAM, right? With similar
Yes, I
color
can
flow
see. Yeah,
pattern.
yeah, that's right. I think it looks worse than just now.
Yep.
And even the MR also looks worse.
Yeah, the MR look worse, but when we measure, it's actually the answer is different. But we will just go through it one by one. So this is M1 across the aortic valve. Okay, just for you who are interested in M1, right? So I'm a big echo nerd. I'm interested in everything. So you can see that this is M1 across the aortic valve. You can see that the aortic valve open, but at the mid opening, it actually closed a little bit, right? It opened, but at the mid part, it closed a little bit. This is a very typical of dynamic LVOT obstruction, where you
Oh,
have a
okay.
mid-systolic closure of the aortic valve. Okay, and you can actually see this in M1, right? As opposed to subaortic membrane, where you can see like almost immediate early closure of that aortic valve. Okay, well, that is number one. Number two, do you notice that this leaflet of the aortic valve is actually fluttering? You see that it's fluttering, right? It's fluttering because you have obstruction below it. And this obstruction causes turbulent flow, and the turbulent flow is actually fluttering that aortic valve leaflet. So whenever at M1, you see a fluttering of that aortic valve, beware, you might be dealing with LVOT obstruction. It can come from SAM or it can also come from subaortic membrane. Okay. Now, look at the M1 across the mitral valve. Anterior mitral valve leaflet open normally and diastole, and you can see SAM here.
Yes.
Open normally and diastole, and you can see SAM here. That is not the only thing that I wanted to show you. The other thing that I wanted to show you is how dynamic the LVOT obstruction can be. That's why, even though a threshold of more than 50 millimeter mercury is considered a threshold to say the patient has significant obstruction, right? The absolute value of obstruction itself, very difficult to correlate with symptoms because it is so dynamic. In the same patient, if you ask them to walk a little bit, you can see the gradient changes. If you ask them to lie down, the gradient change. You ask them to go drink, the gradient change. You ask them to go makan, the gradient change. In fact, from bit to bit here, you can see bit this here. You can see the contact here is not so long. And you can see the contact here is longer. So this obstruction is less and this obstruction is more. So how are you going to manage the patient based on LVOT obstruction, especially to see the progression? You can have a one threshold to see that this patient needs myectomy, but a patient with one echo of 70 millimeter mercury peak and another echo of 90 millimeter mercury peak doesn't mean that the disease has progressed. It just means that the hemodynamic might be different because any reduction in preload and afterload will make the obstruction worse, and any increase in preload and afterload will make the obstruction better. So it is very, very tricky to manage based just on obstruction.
Can I ask you, it may sound like a stupid question, but what is the reason for the SAM?
Right, it's not a stupid question. It is actually the answer is very complicated. It used to be because of what people say because of the Bernoulli principle. Because you have an obstruction here. Because you have obstruction, you have higher velocity here, and you have a lower velocity here. If you remember with the wing of a plane, when you have higher velocity on top and lower velocity on the bottom, Bernoulli principle say that it will deflect or the aeroplane wings above. So the anterior leaflet is lifted towards the interventricular septum. That causes SAM. But even though that is very logical, now we think that that is not really the important reason. What the important reason we think is that because of this increase in interventricular septal wall thickness, as the blood flow from the LA to LV to the aorta, when it hit that thick interventricular septum wall, the flow here becomes turbulent. So you can imagine it go like that, then it go back, it hit here, and then it go like that. It go round.
I
It
see.
go round like that. And
Okay,
it go round
but she has had this procedure, the TASH, like you say, okay. Do you
Yep.
have any echo to show what was the thickness before? Because now it's still very thick.
Yeah, even the thickness come down a little bit from the previous one. I think
And
the
then
section come down from 2.4 to 2.0 centimeter, but the gradient is still there.
I see. So the thickness did come, but the gradient is because of the SAM.
Yep. So you know that when you bring down the septum, the SAM, the gradient should come down because the less
Yes.
thickened, the less turbulent, the less
The less
pushing the
obstruction,
nucleus
yes.
towards the interventricular septum. That is sometimes the drawback with tests. You don't know how, because you just inject an ethanol, right? You
Okay.
actually don't know how much that will cause an infarction. You don't know how much your wall will become thinner. That's why myectomy have much more advantage because the surgeon can
I
actually
see.
see and take
Okay.
out
That
the
is a
septum.
very good point to make. Yes. Okay. I understand now. But
Okay?
what I want to ask you is, now with the treatment of, let's say, myomectomy, can we then reduce SAM?
Yes. When you do myomectomy,
Mhm.
almost 99% of the time, the obstruction comes to zero.
Oh,
So it's a very good procedure. So I really strongly advise all the patients that have hypertrophic cardiomyopathy and SAM, your default position is to go for myectomy. Unless the patient cannot go for myectomy, of course, then you can go for TASH.
so did the patient go for myomectomy?
So what I'm going to do now is that I'm going to do an MDT for this case and try to peer push the surgeon very, very gently and friendlily to do myomectomy.
Okay. I'm sure they'll
Right?
be convinced.
I
Okay,
will
let's have your conclusion. Is there a conclusive slide?
almost. All right.
Okay.
All right.
Yes.
We calculate the ejection fraction. The EF has come down a little bit to 50.6%. Previously 56%. Okay, so it come down a little bit. So this made me very worried, right? Because I do not want her to go into burnout Hawker. Okay, that's why I wanted to push for myomectomy because burnout Hawker when is EF coming down. Okay, so this is the apical four-chamber view. Now, when we look at the obstruction, surprisingly, the obstruction is only 46 millimeter mercury. Okay, this is the best that we can get on our latest echocardiogram, right? But remember that it's very dynamic, right? This is not definite. It is very, very possible. We will never know that maybe as we walk, she walk out from the echo lab, it will go to 90. Okay. So that's why it's very, very tricky. Okay. So let's go for the discussion. We can see a few things, right? Wall thickness come down by 0.2 centimeter. I don't know what's the significance or accuracy of that. EF come down by 5%, probably significant, but remember that EF has a margin of error of plus minus 5%. Okay, so 55 and 50% might not be so different after all. Okay, max obstruction come down from 90.2 to 46. For those of you who are not familiar with LVOT obstruction, you might think that wow, so great, but I think this is most unreliable. The fact that LVOT obstruction is so dynamic. Okay,
So can you also use the fact that her EF came down, therefore therefore the obstruction gradient came down? Can that be a reason?
I mean, when you have, that is possible because when you have EF come down, your stroke
Yeah,
volume
that's right.
and then the gradient come down.
Yes, possible also, right? Okay.
Yep.
So I'm also not too bad. Okay.
What to do next, right? In this patient who wanted to get pregnant young, okay, if she go into burnout outcome, she will die early, much earlier. She will might not go into 40 years old. Okay, so then I do strain, okay, and I wanted to show you the progression of strain from 2021, 2022 to 2024. Okay,
Is her
here is
LA dilated?
really is very dilated.
Yeah, looks big. Yeah. Okay.
Now you can see that the GLS come down from 12.8% to 10% to 9.8%. Unlike ejection fraction, GLS is very robust, is very reproducible. You go and ask a different person to do it, they will get the same answer. Okay, the margin of error is very, very small. So even though the reduction from 12.8 to 10 is only 2.8%, that reduction is very significant. From 10 to 9.2 is only 0.8%. This is very significant. You can see that the LV is actually coming down over time. And I have no doubt that she will go into burnout outcome if we don't do anything. Look at the LA reservoir strain. Start at 15.5%. So the LA pressure is way elevated at rest. But At follow-up, it has come down to 10.6% in 2022. And when I see her, it's only 9.9% now, right? So I think this is my last slide. I think we already almost time already, and I have to do some work as well. I think in these cases, I have proven, I think, however way that I can that this patient need myomectomy, right? I've shown you how to accurately diagnose, how to accurately assess, how to accurately look at the progression, how to see whether the patient is going to burnout outcome. And I do hope that after the MDT, this patient will go for myomectomy, and hopefully that will make her live longer, and she will get her pregnancy that
Yeah,
she
I
wants.
think you cannot subtly tell the surgeon. You have to demand it now.
All right, so I think that's about it. I'm happy to answer any questions.
Okay, there are not many questions. There was one by a doctor, which is not related to echo. He just asked whether GERD can cause shortness of breath. It's possible, but usually it's just heartburn. Okay, and on Facebook, not really, because I have to say that your echo is not like previously where, and this is really hardcore. So even for me, it's a bit something, a lot of new things to learn. So I'm quite interested in this, but it's not easy to understand. Maybe, but as you showed the case from case 1 to case 2 to case 3, then I think more and more people can understand your strain pattern and everything else. So I think all in all, a very good demonstration of something that we have no idea about. And don't work too hard. Yeah.
Oh, all right. Are you talking to me?
Yes, I'm talking to you.
All right.
I know you're occupied with your calls and everything.
Yep. Okay.
Thank
So thank you for inviting me.
Yeah, thank you. And yeah, maybe I'll see you. I gave you another date. But if you're too busy, we'll speak later lah. Anyway, you have
Sure.
agreed to the other date.
All right.
I will just keep it for the
Right.
moment. And then enjoy your babies, enjoy them while you can, because they grow up too fast. You know, yours is 7 months, and my youngest is already 27 this year, and my eldest is 34 this year. So really, honestly, my advice is just to enjoy your kids. Have fun. Bye,
Thank you.
everybody. I see you
Bye-bye.
next week. Next week we have, I think, something on pancreatic CA. And have a nice holiday tomorrow. Happy Thaipusam. Bye.
All right, we're off live. Thank you so much, Dr. Betty.
Yeah, I need to